So if you are new to this channel, I am Dr. Himadri. Let's talk about neonatal jaundice, the second part. Okay. So we will discuss about the treatment part of neonatal jaundice. We start with phototherapy. Now the point is, you can see from this image is that a baby is getting phototherapy, and this phototherapy is of blue color. Now question is, why this is a blue color? This baby is probably a boy, that's why the favorite color is blue, maybe the cause. Please remember another thing. Suppose the baby is a girl, and also the girl likes the pink color, so probably that could be a pink now, but this is a blue. Question is, why this is blue? So remember one thing, we have bilirubin, and this bilirubin is absorbing a light maximum, and which is of 460 to 490 nanometer, and this nanometer light is visibly of blue in color. You can see that is the visible light spectrum 400 to 700, and out of this 460 to 490 is the visible spectrum, and this is visibly blue, that's why this is blue. Okay, now the question is, what kind of bulb we are using? Is a LED bulb or CFL? See, CFLs are outdated. Now we are using mainly the LED bulbs. Okay, now question is, why? LED bulbs are used because this is of longer half-life, that is the machine will run for a longer period of time, and also there is a reduced amount of irradiation, that's IR irradiation, that is infrared irradiation. That's why the water loss is reduced automatically, and also heat production is less. Therefore you can keep this machine very close to the child. As you are keeping this machine very close to the child, automatically the blue light exposure is increased. As it is increased, automatically the effect will be more, and also the treatment will be better. So okay, this is the advantage of having a LED light, and in our setup we are using all those with LED. No CFL is present right now. Okay, now the question is, what is the mechanism of action of this phototherapy? So this is the blood vessel, you can see blood vessel of rather baby, and also this B means actually bilirubin. Okay, look at the image, and this bilirubin is absorbing the light that of 420 to 470 as per Nielsen, 420 to 470. The maximum range is 460 to 490 nanometers specifically. 460 to 490 nanometers specifically. Okay, so look here. So this bilirubin is actually having the formula of 4Z and 15Z bilirubin, and blue light is falling over it, and eventually blue light is converting this compound 4Z 15Z bilirubin into 4Z 15E bilirubin. So both of these are unconjugated bilirubin. Okay, 4Z 15Z and 4Z 15E. But this 4Z 15E molecule is an isomer. This is an unconjugated bilirubin isomer, which is basically excreted via your biliary system. Okay, coming from the liver, unconjugated bilirubin, the isomer is unconjugated, which is coming from liver via bile and eventually flushed into stool. Okay, but this isomer is an reversible isomer. That is, if the light is not falling here, automatically it will reverse back into its prior configuration. That's why this is not important. But the second point, the second mechanism is the most important mechanism. Please remember this by heart. Okay, so unconjugated bilirubin is converted into lumirubin. Remember this, lumirubin. Lumirubin is an unconjugated irreversible isomer. The first one was reversible isomer, but this is irreversible isomer, which is flushed into your urine via kidney. This is being flushed, and this is the major mechanism how this unconjugated bilirubin is converted into lumirubin. Okay, so now the indication for phototherapy. So indication for phototherapy, remember, when we have TSB which is in phototherapy range, okay, we will discuss about this AAP, that is American Academy of Pediatrics has already given a chart which is also present in your OP-GAI textbook. So number one indication is when this TSB value, total serum bilirubin, is above this phototherapy range, and also when the clinical features of BIND, that is bilirubin induced neurological damage, is present. And what are those points for effective phototherapy? Number one is there should be irradiation of visual light at least 30 microwatt per centimeter square per nanometer. Okay, and also the wavelength should be 460 to 490 nanometer, because this is the absorption spectrum of our unconjugated bilirubin to be converted into lumirubin. Okay, so now the baby is getting the phototherapy, and remember one thing, the distance should be minimum as possible, therefore to increase the exposure of this light more. Therefore, the distance should be as less as possible to increase the irradiation. And also remember one thing, when we are giving phototherapy, we are actually covering the eye of this baby as well as the diaper area. Okay, we are covering with the diaper, and this is the only area we are covering, except from this area whole body should be exposed. Okay, and should be open to get the phototherapy as maximum as possible all over the body. And another thing, suppose and this is obvious that the baby will get the breastfeeding, but that session should be less than 30 minutes, should never be more than 30 minutes. So the baby is on phototherapy, you should give this baby to the mother, and baby should receive the breastfeeding, and this should be less than 30 minutes always. Okay, so now when to stop phototherapy? You can stop phototherapy when the TSP range falls below 2 mg per dl from its previous cutoff that we are getting in that AAP chart. Don't worry, very shortly we will show you what is that chart given by AAP. Okay, so the TSP level falls below 2 mg per dl of the phototherapy threshold that we are using to start this phototherapy. So now the contraindication for phototherapy. Contraindication is if there is congenital porphyria or family history of porphyria is if present, this is actually absolute contraindication. You should not give phototherapy. Okay, suppose you have given phototherapy in a patient with congenital porphyria, the main problem will be that there will be immediate severe blistering and agitation. And the relative contraindication, remember, is the cholestasis. You should not give phototherapy when you know that this is a conjugated hyperbilirubinemia, that is cholestasis. Okay, so now the side effects. If we give phototherapy for prolonged duration, of course there will be some side effects. So remember, there would be erythematous rashes, red colored rashes all over the body because of prolonged phototherapy. And another thing is transient diarrhea. This is commonly seen in phototherapy cases. Okay, and another side effect, if wrongly given in a cholestatic child, cholestatic baby, there will be bronze baby syndrome. Bronze baby syndrome means the baby will look like a dark brown in color. So another form of phototherapy is called as your Billy blanket. Billy blanket is actually, this is a total blanket made up of multiple optic fibers. These optical fibers actually produces this blue light, and this blanket is covered like a blanket normally done. So therefore the more amount of irradiation of this blue light, therefore more work. The main cons about this Billy blanket is that this is highly costly, as this is highly costly, not available in all the centers. Okay, so this TSP is very important. You know, TSP is a main thing from where we actually starts this treatment, and this TSP is measured by Vandenberg reaction, that is colorimetric method commonly done, or maybe in the micro method, that is spectrophotometric method or optical imaging. And another thing is the HPLC, high performance liquid chromatography. This HPLC is not routinely done, this is reserved for your research purpose. So this TSP value in less than 35 weeker, we use NICE guideline. Okay, for more than or equal to 35 weeks of gestational age of the baby, we use AAP, American Academy of Pediatrics 2022 guideline. This is the latest guideline which is also present in your OPGHI textbook. This is the NICE guideline. This is your phototherapy range. Look here, no risk factor. Remember one thing, no risk factor. The child is not having any risk factor. So your 35 weeker, this red color, 36 weeker, this 36 weeker or more, this color, that is orange color, and blue color eventually. And I will be uploading this PDF in our Telegram group. Make sure to download that. Okay, and you can also get it from OPGHI textbook as well. This is the real which I actually got from the AAP. And another thing, this is for the with risk factor. Therefore, you should know what are those risk factor in the neonates. Okay, so hyperbilirubinemia neurotoxicity risk factor. Number one is your gestational age less than 38 weeks. That is if the gestational week is less, that is the more the premature baby, more chances of having this neurotoxicity. Okay, and if the albumin is less than 3, this is also a risk factor. In isoimmune hemolytic conditions like in G6PD deficiency, Rh incompatibility, ABO incompatibility, and also the sepsis of that baby, and also maybe significant clinical instability in the previous 24 hours. Okay, now the second treatment modality we have is exchange transfusion. We call it DVET, that is double volume exchange transfusion. Okay, so remember, this is most effective method of reducing your bilirubin, and also it reduces the bilirubin very rapidly. When you are giving this double volume exchange transfusion, after giving it, your TSB value will come down by 50%. Suppose initially it was 30, it will be 15 just after this therapy, and it replaces 85% of your circulating PRBCs, that is circulating RBCs. And the technique we use is pull and push technique. We'll show you very shortly. We use umbilical artery catheterization as well as umbilical venous catheterization. In the umbilical artery, what do? We actually pull the blood and push the blood via the vein, umbilical venous catheter. And we are doing double volume exchange transfusion. Double volume exchange transfusion means 2 into 80 ml per kg. Remember this. That is 160 ml into the body weight. So 2 into, in case of this 3 kg baby, 2 into 8 into 3, that is 480 ml, and 2/3 of it should be given by PRBC, and 1/3 volume should be replaced with FFP, that is fresh frozen plasma. The choice of blood products in DVT is very important. Remember this. We have already discussed it in our first part of this video. So suppose the diagnosis was Rh incompatibility. So what will be the blood that we will use for DVT? Look, one thing, in case of Rh incompatibility, always give Rh negative blood. Usually we use the baby's blood group here, and we can also use O negative blood group, but always negative, that is Rh negative. And FFP would be of same, that is negative, but it is of AB, that is AB negative. In case of ABO incompatibility, what we should do? Remember, the PRBC will be always O. Always O PRBC should be given to the baby, and Rh will be that of a baby. Suppose the baby is having positive, give positive. If a baby is Rh negative, initially give negative, like that. And FFP is AB, and also the same Rh. Okay, so what will be the monitoring after doing this double volume exchange transfusion? We have to monitor the TSB value. Should be done after 2 hours, after 6 hours, and 12 hours, like that. Okay, now the indication for doing double volume exchange transfusion, you already know it. If the TSB value is more than exchange transfusion range as per the given chart of AAP, okay, and also AB, that is acute bilirubin encephalopathy, and in case of Rh isoimmunization, if the cord blood is having TSB value 5 mg per dl or hemoglobin is 10 mg per dl, like that. So what will be the side effect of doing double volume exchange transfusion? You are intelligent enough, rather more than me, to understand what could be the problem. This is a massive transfusion, okay, so therefore there will be volume overload, there will be hypocalcemia, and also cardiac arrhythmia because of electrolyte imbalances, like that. Graph for exchange transfusion without risk factor. Risk factor is same, and this is exchange transfusion with risk factor. So one thing you must know here, in the double volume exchange transfusion, what was happening? So this is our umbilical vein. You have to do catheterization in the umbilical vein, as well as in the, these are 2 umbilical arteries. You need to insert your umbilical catheter in one of these arteries as well. Look at this photo. This is your UVC, umbilical vein catheterization. This is UAC, umbilical artery catheterization. Via umbilical vein catheterization, we need to put the blood, that is we are we have to give the blood via this UVC, and also in the UAC, umbilical arterial catheterization, you need to draw the blood. Therefore, this technique is called pull and push technique. You are pushing the blood via UVC and you are pulling or drawing the blood via UAC, that is umbilical artery catheter, and this blood is actually kept in the drainage bag and eventually thrown. So you know these steps. Okay. So now few words about your prolonged jaundice. We talked earlier, prolonged jaundice is basically part of pathological jaundice. So if the jaundice persists for more than 2 weeks in case of a term baby and more than 3 weeks in case of a preterm baby, we call it prolonged jaundice. So the first thing in prolonged jaundice is we have to rule out the cholestasis part. And after that, we can actually come to the diagnosis. The first, remember, breastfeeding jaundice, BFJ. And second cause is breast milk jaundice. Breast milk means some constituents of milk is doing this jaundice. And third thing is your RH or ABO incompatibility. These are important. The fourth cause will be your congenital hypothyroidism. Very important, congenital hypothyroidism. And also your cephal hematoma, we talked earlier, a huge amount of blood, and eventually there is this jaundice. And sixth is your Crigler nasal syndrome type 1, type 2, Gilbert syndrome, and also there could be some causes like GI obstruction and malabsorption associated with that, or maybe Hirschsprung disease like that. So these are important causes for prolonged jaundice. So few words about breastfeeding jaundice. Breastfeeding jaundice means the child is not getting enough amount of breastfeeding, that is the milk. Child is not getting enough amount of milk, that is the reason there is your jaundice. Okay, so what could be the cause that could be attributed from baby? Late preterm baby, 34 weeks, 36 weeks, ineffective sucking technique, that is the sucking is not well developed, or it could be small baby illness, therefore the child is NPO, nil par oral. And the mom's cause, or some contributing factor from moms is like improper feeding technique, or maybe some infection in the nipple, cracked nipple, sore nipple, and that's why the child is not getting enough amount of milk. So therefore there is issue. Okay. So how will you suspect that this is a breastfeeding jaundice? Remember one thing, you need to measure the weight. If the child is not gaining the weight appropriately, you can easily suspect that there is some issue with the breast milk. That's why and also the child is having jaundice. So the two issue you can easily correlate from here. So second thing, breast milk jaundice. Breast milk jaundice means in the milk there are some constituents of the milk which is responsible for this jaundice. Only 2% of these exclusively breastfed neonates will have this breast milk jaundice, and it usually starts at the first week. It continues till 3 to 10 weeks. Remember, and that is after 7 day, around 8 day or 10 day, around 10 day, the child will have the jaundice. The jaundice will be maximum at 2 to 3 weeks of age, that is it will be 10 to 30 mg per dl, and it will continue for more than 10 mg per dl as a range for 3 to 10 weeks, and after 3 to 10 weeks it will eventually subside. So this is called as breast milk jaundice. Remember, some constituents of milk is responsible for this jaundice. So here conjugated bilirubin is converted into unconjugated bilirubin by a naughty bacteria causing some products like beta glucuronidase, which is responsible for this. But this milk contains some products which are called as pregnanidiol, and second thing is fatty acid. Please don't forget this pregnanidiol and fatty acids, beta glucuronidase. These are responsible for your breast milk jaundice. Because of some constituents of milk, there is some jaundice. The treatment is very easy. Continue breastfeeding. Even if the breast milk is the culprit, please don't omit it. Just continue. Okay. The treatment is continue breastfeeding. Okay. Some few words about BIND, that is bilirubin induced neurological damage. The problem is, suppose the baby is having jaundice. What will be the issue? Baby will be yellow for a prolonged period of time. Baby will look like orange. The color will be like orange. But what is the issue? Is there any problem? Yes, there is definite problem. The problem is with the bilirubin. This unconjugated bilirubin, which is present in the blood with the albumin, because this is not water soluble, this is rather lipid soluble. This is extremely toxic. This unconjugated bilirubin is, remember, extremely toxic for your brain. It goes into your brain and eventually deposits there and eventually causes severe damage to the brain. Remember, this is your blood brain barrier. And another thing, the blood brain barrier could be damaged in some causes, like in anoxia, in birth asphyxia, in hypercarbic situations like in sepsis, birth asphyxia. These are the conditions where blood brain barrier is improper, that is permeable, more permeable. But in other conditions where the unconjugated bilirubin is very high, suppose your albumin is less, if there is given ceftriaxone dissociates the albumin from the unconjugated bilirubin. Automatically, this more amount of unconjugated bilirubin as well as your blood-brain barrier is weak. Therefore, more entry into the brain. Remember one thing, and it eventually goes and deposits into your globus pallidus. Okay, so in the your lentiform nucleus, in the globus pallidus, this is actually deposited. So there are two types of bind. One is acute AB, acute bilirubin encephalopathy, and another is chronic. The chronic term is also known as kernicterus. This acute form is divided into three parts. One is your stage 1, stage 2 and stage 3. Stage 1 is reversible, stage 2 is partially reversible, stage 3 is totally irreversible. So if you are still watching me, probably you could have liked this content. So please give a like, and also please don't forget to subscribe for more such videos in the future. Okay, thank you.